scenarios. This is the best case scenario of a HIV care continuum, that is from a HIV diagnosis to achieving sustained viral load suppression. So in between these, we ensure that the patient is linked to care, he is on treatment and retained in care. So and in we see leakage in patients actually in these different buckets as the patient passes from red color to orange, orange to green, green to blue, and then violet. You see different places where there could be a potential uh, loss of patient or trying to have a disengaged care. Now further, next slide, this is a very important slide that you would also, most of you would have seen in the capsular training too. So we use the same slide here today. So if you see stage 1, basically you have identified the patients in ICTC, but we could not link them timely to ART centers. So even before they were initiated on antiretroviral therapy, or they could not actually reach the ART center. So this is one loss where we are seeing, and this is very important as part of the MPR. When you look at in the current cascade, if you're trying to monitor your own center, what you have to see is number of patients who are registered and number put on ART. So if you are getting patients who are not yet put on ART, that means these are the patients whom you are missing out and who are potentially who will be missed out. Second important step is once we engage patient into care, register into our care, after that there is a loss. So that is ART defaulter or ART loss to follow. And then you have, after the initial initiation period, you have anytime after that, the patient may also mistreatment or is an LFU over the course of treatment. The other leakage that we have is, again, prevention is one other important cause of a loss of retention or loss of retaining patients in care. But there's a different topic altogether. Here today, we will only get to the aspects of how do you prevent that loss to follow-up or treatment interruption. And if somebody is coming back to care, what is that acknowledgement we need to give to that patient whenever they are coming back? So this is again conceptualizing engagement with HIV care. What I want you to take away from this slide is not all patients will behave equally towards or respond for taking antiretroviral therapy. So it is basically how much they understand, how much they are self-motivated to take this, how much they are able to retain the knowledge that you have given, and then they also should understand what is the public health impact of they being suppressed within the family and to the community. So this is a vicious cycle, and there are so many factors you see which influences that. Sometimes the health system factors in terms of possibly there could be some stigma, discrimination, some contextual factors. If you take possibly there is no health facility where he can actually access, it is too far to travel. So these are all some of the barriers or some of the influential factors that actually influence patients to take antiretroviral therapy. Now, as we look into retaining patients on ART, we have to first give importance to prevention of treatment interruption or loss to follow. Usually what we do is we give more emphasis to retrieving patients who are already lost to follow. And to for to bring back one patient who was lost to follow up, it takes so much of resources in terms of, number one, the ART staff should keep calling the patient to understand where he is. If they could not reach him over phone, then somebody should be visiting the house, and that a house visit will be repeated for at least 3 months. So this is all the resources that we are investing in getting back one patient. But what if we would have had the same um, resources invested while we are initiating ART itself and while the patient is in care? If we would have taken extra responsibility, extra care, possibly we would not be actually going to the stage of home visit, but we would actually prevent a loss to follow-up. So this is the concept of preventing treatment interruption or loss to follow-up, rather than going and trying to get back the patient whenever there is an episode of loss to follow-up. Right. So if you see, uh, one important thing as we are seeing here is, if you have to prevent loss to follow-up in the first stage, please listen carefully. These are some of the examples we are just discussing. So if you have to prevent loss to follow from step 1 to step 2, some ART centers, what they are doing is they are transferring out the patient even before registering them in the ART center. So if you do like that, what happens is there is no responsibility. You just tell the patients, no, you're not from here, and even refer the patient to their ART center, which is closer to them. Patient may go or may not go. But if you would have registered here and then you would have officially transferred it through a transfer route format, then even if the patient is not going back there, there will be a possibility of our outreach staff or the care support centers getting in contact. If you would have not registered and just send the patient, go to the other center, then it is no one's responsibility. The patient cannot be tracked. So this is one important thing that we need to have, that we need to understand. Whenever there is a patient coming, please do not transfer out without registering the patient. Next, look for PLHIV who is discharged from the inpatient wards. This again, in a high load centers, what we are looking at is there are HIV patients who are coming there. Once they get their HIV diagnosis, the inpatient facilities, either they are discharging or the patients are going against medical advice and getting discharged. So this again is a missed opportunity for us to get these patients put on antiretroviral therapy or give a counseling and then refer to their place closer to their residence for antiretroviral therapy. So possibly some states, some ART centers, I can give some examples, like in Mumbai, the staff nurse there actually visits the wards regularly and then tries to find out if there are any HIV positive patients. Either they go first to the ICTC and see if somebody is diagnosed there, or directly go to the inpatient wards and ask. And some of the ART center superintendents or the nodal officers, what they have done is they have ensured that there is a circular sent out to all the inpatient facilities that if you have an inpatient HIV positive patient, please ensure that they are referred to an ART center before discharge. So these are some of the things that we could put up in our own centers with the support of the hospital where the center is established, so that we do not miss an opportunity of actually getting that patient put on antiretroviral therapy as early as possible. Then there are certain other mechanisms where you have some Disha or the DAPCOs who are currently there. They maintain a systematic line list of patients who are diagnosed at the ICTCs and trying to identify during their monthly review meetings whether these patients are reaching ART center or not. So these are some of the mechanisms what some of the centers can adapt based on their contextual factors where they are and how best they can do. So this is one way we could prevent the treatment interruptions or loss to follow up. And everybody go to your chat box. Now, if a patient is registered on ART and you are not putting the patient on antiretroviral therapy, okay, so when do you call a patient as a pre-ART LFU? How many days will you give? Can you put your answers in the chat box? We'll wait for 30 seconds. So what is the time duration for a pre-ART LFU? When do you call a patient a pre-ART or a pre-treatment loss to follow-up as per our operational guidelines? This is very important again, because we are giving some time period. Within that, we want to ensure that the patient, if he is registered, we are calling them immediately so that we do not give that time period where the patient is losing. So what's the time period? Let me check. Wow. So all of you are correct. So it's 28 days. So 28 days is the farthest date that NACO is or the operational guidelines are telling you. Not that wait until 28 days and put a remark as pre-ART LFU, but we need to start tracking that patient if they are not coming back immediately after the first contact. And what again in some of the centers the data says is If somebody is having an opportunistic infection, usually they are the patients whom you are delaying antiretroviral therapy. So if they are coming to a center and having a clinical contact with the ART center, and you know that, that's fine. I'm not saying start ART. I'm saying if they should be having a clinical contact within those 20 to 28 days, and if you know the reason for delaying ART, that's fine. But if you are not having a clinical contact with the patient within 28 days prior to starting of antiretroviral therapy, then you actually classify this patient. And thank you all for answering that. Now, linking to care. Now, the patient has actually come to you, to your ART center, and you have done a very systematic review of the patient, the ART staff, from the care coordinator to everybody in the staff. This is a collaborative effort as a team effort. That's why during the capsular trainings, we were stressing more on the team efforts rather than an individualized care, an individual staff providing the entire package of care. Now, there are guidelines in our own guidelines that if you have a very high load LAC plus center, if it is working and by intimating NACO, there is still again a possibility to minimize the linkage loss from a link ART center to an ART center. If you think an initiation is possible, there is a very good cooperation from the hospital staff, and the medical officer there is willing to start ART with a good staff nurse from the LAC plus. Possibly these are the options we could think of, starting ART there and linking robust linkage with the nodal ART center. And some centers in Northeast where we have a difficulty in terrains, there again initiation, trying to link the patient like our ESASEP, link to the EART and do it. So there are certain states who are doing. So if there are still modalities where we are ensuring that a patient is registered in care, but we are not losing them. And preparedness and rapid ART is one other thing that we need to focus. And focus on a newly registered. When you're tracking, you please focus on newly registered patient. Don't just limit yourself to who are not initiated. Okay. So newly registered, after not initiated after 28 days is an LFU. So we do not want to do that after a pre-ART LFU status. We want to do a very active tracking even before the 28 days. And then for step 3 and step 4, we will go into the package of services that are very detailed within our national guidelines. But overall, these are some of the strategies that you could think of apart from the routine that you do at ART centers. Bear in your mind, there are good approaches that we could do at our local context, putting SACS informed, DAPCO informed, NACO informed on what is the additional thing that we are doing. Is it appropriate patient-centered care that we are thinking about to prevent an interruption in treatment or LFU? Yeah, so I hope everybody has gone through this patient-centric differentiated care packages for retention. This is a very good review within our national operational guidelines, and mostly I'll be discussing from this same chapter. And if you see on your left, some of the states are doing a very good uh, arranging the white cards so systematically so that you do not have any confusion when the patient is coming. So there are different mechanisms. We will see some of the examples as we go through. This again, I think most of you are aware of this slide, what we used in our capsular trainings. If you put one step ahead, okay, we are going one step backward, 2 steps forward, 1 step backward. So we are not actually giving the dent on that net new that we are looking at. So this becomes a very important session for us to understand how to prevent this happening. So if you have seen this framework of patient-centric packages of care, what we are doing is we are dividing the entire care into 3 different buckets. That is, initial 6 months is the very critical period where we are losing patients. So what is that we should be doing there? And after 6 months, what is the type of care that we should be doing? Your own center data, if you start analyzing, you will definitely see that the patients who are lost to follow-up or dying are within the first 6 months compared to other compared to other duration of antiretroviral therapy. So please start doing this patient-centric packages of care. Try to prioritize your patients. Now, why NACO is put this framework within our national guidelines is that you want to prioritize the patient who should be getting that definitive and the tailored care. For example, a patient coming with a CD4 count less than 200 needs your extra time compared to a patient who is coming with a CD4 count of 500 at ART initiation. Somebody with an unsuppressed viral load needs your time compared to a patient who will have a suppressed viral load. So that is how the design of this patient-centric packages of care is well established. So I again urge all the centers to start practicing this. This is going to help both of you, both the patient and the care provider. First of all, it will help the care provider to understand which patients requires your utmost time and support, or the counselor. And you also want to understand who are stable in your center. Sometimes when we think of a very big center, suppose there is a center like Kakinada in Andhra Pradesh, which sees almost around 10,000 patients. Okay, but they know that 80% of their patients are stable. They need to worry about their 20%. So they try to maximize their time to those 20% of the patients rather than those 80% who require that routine care. So how do they do that? They start trying to triage which patient belongs to which package of care. Now, within the first 6 months of the patient getting registered, this is a critical time. So this is a package A, we call it. All newly registered patients, until they get their first viral load, they are part of this package A. And if somebody has a CD4 count less than 200, he needs to be put under an advanced disease management package of care. So they are A plus. And B is patients after B and C comes only after you have your first viral load. So after that routine first viral load or 6 months or the annual one that the patient undergoes, based on that, we triage the patient either into a B or a C category. In a B category, you have all stable patients. That means they are virally suppressed. And in C, you have unsuppressed. Okay. Now, again, use the chat box. I'll just give you a couple of instances. And you have to just say in which package of care. So you have to just say B, C, or D. Okay. So now you have a patient who is coming, who is on care on ART for more than 1 year, and his viral load is less than 1,000. But after his viral load, the patient has now become lost to follow up, and he came back to you after 1.5 years. So where do you put this patient into? Patient on ART for 1.5 years, now lost to follow up. Where will you put that patient into A, B, or C category? Just put in a chat box A, B, or C. That's it. Anybody else? 10 seconds. Yeah, good. So it's basically all re-engaged patients. That is, whom you are retrieving, you better put them under package C. That is, these are all unstable patients or virally unsuppressed patients is where we are putting. They may have a CD4 less than 200, but don't worry. But if they had a viral load in any instance, they're coming back. We want to deal them specifically. So we are putting them under package C. And stable patients, you put under B. So if you start doing this, then you will understand what is that great amount of patient load that I need to spend time on. Now, I want you all to focus for 1 minute on this slide and look at what are you providing the patient in package A. Very important things that we need to bear in mind if you really want to prevent death and prevent loss to follow up. The calling of these patients, okay, every 15 days for first 3 months and then monthly until 6 months, that should be very, very, very important to track that patient. That means you need to have a correct phone number. And the CSC, you take help of CSC staff if required for tracking through home visits. This is the period where you invest in home tracking if they are not connected through phone. Later on, after 1 year, after 28 days, if you do that, you will not have much yield on that home visits. So this is important. Second important thing that we need to ensure is the counselor or the case manager there, whoever is taking care of this patient, should really convince the patient, should motivate the patient, and the patient should understand that this is a lifelong therapy. And yes, taken once, they can actually suppress the viral load to an undetectable level. It is going to be helpful for himself and to the family members too, and for the community at large. And do a very good TB screening, putting them on TB preventive therapy, cotrimoxazole prophylaxis. So all that goes. But very important is the tracking efforts that you're putting after an LFU. Double the amount of that you need to put in this first 6 months so that you don't lose them. And our own data for each center says that your LFUs or the mortality is higher in the first 6 months. And if somebody is having um, a CD. Okay, can anybody put up again in the chat? What do you mean by advanced disease management? Just tell me the CD4 and the clinical staging. So if a patient is coming with dash CD4 and dash clinical stage, ADM, and do you call that the patient requires an advanced disease management? Yes, Shivani madam has put in. Good. Yeah. And also you also have to consider CD4 too here. CD4 is also in stage 3 or 4, regardless of CD4, you can also put them here. So this is an important thing that most of you know, but what is in that package is what you should understand. That package has, very importantly, do tuberculosis screening very thoroughly. Put the patient on TPT if you have ruled out tuberculosis, very important. Start antiretroviral therapy rapidly. Third important thing, if you do not have a crack within your centers, the national guidelines recommend starting everybody who is in CD4 less than 100 on fluconazole preemptive therapy. So this again is another important thing. Cotrimoxazole prophylaxis to all with CD4 count more than 350 and adherence counseling. This is the package of care that we need to provide for advanced disease. And top of that, the calling activity and referring this one. And very importantly, now you see within your own ART centers, every initiated patient, prospectively we are going to do index testing. It has already started. The momentum has caught up now. Index testing is one other crucial element of the package A of services that we need to be doing. And package B is differentiated service. Package B is you do in routine to everything. You can do a decentralization, you can put, if available, multi-month display. All these can be planned in this patients who are in package B. Package C is again unstable, that is the viral load is high in this patient. These are another patient groups whom we need to have that enhanced adherence counseling being monitored, thoroughly done, and calling the patient immediately after we receive viral load results of more than 1,000, and try to do a very thorough, in-depth, personalized and tailored options for these patients whom we actually do a very systematic collection of of counseling using our EAC checklist. I'll show you in the next subsequent slides. So EAC checklist is one we need to start using. And then there are some key populations possibly who would be in this group. Possibly they will require some specific care. We need to link them up to some TA NGOs or any place where they have their own community. And package A, this is what we are saying. If it is not possible, you see in this picture, in the morning waiting hours, the counselor there and the care coordinator there are providing a group counseling. And if you do not have time, if you have high volumes of patients, this is another one mechanism how you could have that common messaging to all patients even before the dispensation starts on that day. But bottom line is, these are the very, very, very important patients that we should never be missing them from our care. So as I told you, telephonic tracking by ART every 15 days for first 3 months. Once after that, this is to be done by the ART counselor, and not many initiations you get. The maximum, if you have even the highest load, maybe 50 to 60. If you put them per day, you have some 4 to 5 initiations. Yeah, of course, there is some variability, but the highest proportion of time you should be investing is in these patients. Now I'm showing you another one important thing. What if you have called patients within 48 hours of missing therapy? We put in our guidelines, right? You call the patients within 48 hours. So this is one example from one state. What they have done is during July to September 2023, they started to call patients successfully. They saw around 79 patients they were able to 79% of the patients they were able to call, and you got back around 85% of them. Next quarter, 78% and 84% of them came back. That means if you would have not done that immediate call back within 48 hours, possibly you would have not got them back, or they would have not got the message that it is an emergency for them to come to the ART and collect their pills. And the other important thing is, if you have good phone numbers, this is the advantage. 80% of successful calling is not a joke. It's like you try it out in your own centers. Later, you can tell me anytime, whenever we visit, or you can text me and say, are you able to reach these 80 to 85% of successful calling? That means a very simple technique, what some of those centers are following are just stick a paper behind the medical officer's chair or the counselor's chair. If you update, if you have an update in your address or telephone number, please let me know. Because this message we cannot tell during every visit to every patient, but these are some of the things. If you display it, possibly at least 2 in 10 may see that and tell you that there's a change in their address or in their phone numbers. Okay, so these are some very small but an efficient ways of increasing the efficiency of bringing back the patients if they do not come on time. And for this very important thing, the basic thing what we need to have in our hand is the daily due list, which should be generated. Yeah, these are again some of the examples. On the left, what you see is this is a practice being done in Mumbai. So they have, the SACS has ensured that they start triaging the patients. For example, if somebody is not coming within 48 hours, that's a high priority card. It will be on the top and they need to do a phone follow-up. And there are certain other centers, you do a very low cost setting. You see that they are trying to put the cards. If a patient is not coming today, they put their card in this bin. This is an M1, maybe 48 hours after that, if they are not coming, they put it in that bin. When you see that there are more number of cards in that bin, that will stimulate you, that will make the ART staff understand that, oh, I have missed so many patients today. But if you have one list of 100 patients, you're not going to see so many cards, and maybe you may not be motivated enough to call all of them. But this is one way where the staff are moving around, and even if one of your staff sees that today we did not get so many number of patients who are supposed to come today, and you start calling them up. So this is one way to show you the volume of patients who are yet to come, and you do not want these cards, more number of cards in M2, M3, and definitely not in LFU. Next, package B or C is only after 6 months on ART based on the latest viral load. Again, spend a couple of minutes on this slide because I still see some of the centers having difficulty in understanding that there's no definition for stable children. There is just a definition here: more than 2 years on ART for 6 months, suppressed viral load. Because what we are seeing here is the children are there in one center, parents are there in a decentralized site. And centers, I mean, because either you do not have a refresh of the guidelines, did not read or not aware, still you insist those patient families to take it from the center which is far away from their residence just because the child is there. So these are the guidance that you need to have. When do you, what is the leverage that we have within our operational guidelines for children and for adolescents? Now, package B is if you have 100 patients in your center, definitely you're going to have more number of patients in this package. So what all we can do is for these stable patients, they need to be given a time relatively less than patients who are in A or C category. So these are the group of patients in whom you should plan for decentralized care, or whom you want to send them to link ART center, or any carg model you want them to send to a community, sorry, or a TI where there is a dispensation can happen with the TI NGO. So these are several other opportunities for multi-month dispensation. But as ART center, you need to understand who are these patients. Only when you know who are they, then you can plan whom should you be referring for such models of differentiated care. Now, is it possible to triage in a high load center? And if it is possible, what proportion you anticipate in category P? Suppose think there are 100 patients or 1,000 patients in your center. What proportion of your patients do you think will be in category B? Can you just, this will vary from center to center, but I just want to see what are the proportions that you are thinking or you have seen in your patients. Can you just put up percentages like 50, 60, 70, 80, 90, 100, whatever you think? Can you put in the chat box? Only two of them have put. Another 20 seconds. We have 260 people. Not even a quarter of responses I got. Okay, last 5 seconds. Okay. Okay. So one thing is it. Okay. So this differs from center to center. But most of you, if you see on an average, you say that it is between 80 to 85% on an average. That's what we see. Right. I think you're all almost there. So this is from one state. Okay. Almost they had so many number of patients, almost 2 lakh patients were there on ART. When that state had done this activity for all their 202 lakh patients or 2.2 lakh patients approximately on ART, they found that 80% of their patients are in category B, and 9% are in A, and 12% are in category C. And see, beautifully, they started to sticker there, and they know which patient is to be offered which type of care. So it's not impossible. The bigger states have done it. So just now, how they are using it is they are trying to now decentralize and give options to patients for uh, decentralized care closer to their residents, and they are trying to prioritize patients who are virally unsuppressed or coming back from LFU. So this is how you can manage your time and prioritize your time within even in a high load ART center. So see here, this is what I was saying. You know your patients when they come back, you're seeing and here stacking of drugs also, sorry, the cards you see, they also put A plus and C on the cards that they are putting it up. See, you have all B category. So there are ways and means locally you can work out with your own ART center. You are the ones who have that ground intelligence, how best you have to serve your patients and how best you have to ensure that they are retained in care. So these are some of the examples that I'm just showing you from some states where they are following. Now, this is another very important one. Uh, what some of the centers are doing is they're also doing some camps. For example, if there are some patients who are in LAC and they are unable to travel, or there are patients who are in a nodal ART center but have difficulty in traveling. So they identify a nearby LAC or any other public health facility. The DAPCOs there or the staff from the ART center calls these patients, try to group them in one site and conduct these comprehensive health camps, or a health camp where they actually do different things. Okay. So they can be done. It's not easy. These are all differentiated care that we need to do. This again, you in your respective states, you would be having some child-centered cares, some orphanages or some child care homes. What we need to identify as the ART center staff is there any one or two people in that particular center who could actually monitor their own peer groups taking these drugs? Because the attendant or the person in charge there may not know about the drug, but the person taking there, and you identify a peer leader who could actually ensure that their own group of children start taking the drugs. And if you see here, they have also identified who is that patient, what is that, how much of the drug they should be giving, what is the type of regimen he or she is getting. So all these are important because in a setting, this is basically a community setting where you have children, or sometimes you also have another homes. So there you can institute mechanisms, because all these people may not be coming to your care, all of them. So couple of them will come and pick up the drugs and go for the others. So you definitely want them to give you the adherence of the other patients who are children or adolescents who are there in those centers. And another one example is you also have some TA NGOs whom you have more number of patients there. So possibly there you could try out a dispensation directly from those community members. And if there is any treatment interruption, the same peer educator who is there part of, or the ORW part of the targeted intervention, could be followed up, because the TI ORW or the peer educator is more close to their community rather than the ART staff, because they have been seeing him or her since the time of diagnosis. So this is one other mechanism we could look. All these are for category B. And you have different modalities where you have these differentiated care things, like group models. For example, you have this family-centric care is one other very good example, where we are seeing in certain states who are actually implementing that family-centric care. We see that the retention are really higher in them, and the children are coming back for their routine viral loads regularly, because we are monitoring the child and the parent as one single unit here. So the suppression rates among children are pretty much higher in places where they are seeing the family as a unit. Right. And some states, they also look at adolescents whenever they are coming to an ART center. They identify peer groups or peer leaders who actually gives them some sort of messaging. And also there are some counselors who are exclusively trained how best to take care of these adolescents. So states can start trying out this. And package C, this is very critical, because now the patients are coming with a high viral load here. And if they are coming with that, the very first step that we need to understand is enhanced adherence counseling is one important step, and timely referral to SASIP. If switch is required, switching on appropriate regimen, and ensuring that they do not miss treatment. So I'm giving you one example here. Just look at a table on my left first. That is, see the time period from October to December. In that quarter, almost 4,000 patients were retrieved from LFU in one state. Okay. And what happened? I have seen them at the end of next quarter. That is in the month of March 23, I have seen them. When I saw that, almost 27% of the patients were lost to follow-up by next quarter itself. So you also can see that if a patient is coming back to the ART center from an LFU, we are seeing these patients losing by the end of next quarter or next 3 months. So the learning that we have to get from this slide is patients who are coming back are really, really very important to us, because they are going to again interrupt their treatment within the next 3 to 4 months. You see that almost 40 to 45% of these patients will definitely have a loss to follow-up status within the next 2 or 3 quarters. So when we know this reality, when we know this one, these are the patients whom we need to really take care of. So we call something like a welcome back, uh, uh, welcome back to them, or a re-engagement package of care. Usually what happens is the first step is very critical. You need to first understand whether this patient is a LFU patient who is coming back to you or not. If you don't identify that and acknowledge that this person actually is coming back after a treatment interruption or an LFU to you, then you are giving the same old care what he was getting, and he will not, and he will, the barrier why he is not coming cannot be addressed. So the first very important thing is, please acknowledge the patient who actually is an LFU or who had missed drugs. If you are missing this first step, then he is into the fold of any other patient. And in the field, I mean, I have interacted with many of our outreach staff. In person, I visited some retrieval mechanisms too. What I learn in the field is that actually the outreach staff do a great, wonderful job. While they go to the field, they tell them that it is very important to go back to the center. The medical officer will take care of you when you go back. The ART staff will be really welcoming you, and please go there. So by hook or crook, they ensure that some of them come back here. And of all that information they get in the field, and if I as a patient as coming to your ART center and you don't even acknowledge me that I am a loss to follow up, or there are some other extreme things we do in terms of shouting, scolding, or doing something, we definitely will lose that patient. That's what the data is staring at us and telling us. So the important message I want to drive is, please focus on patients who are coming back to you, because you do not want to again drag them. And please use your own EAC checklist that you are using for patients coming with a viral load more than 1,000. What checklist you use there, the same thing you use, and treat this patient as a category C patient, and give that extra effort of calling this patient every 15 days like you're doing to a new patient, and ensure that the barriers that the patient is reporting, try to mitigate those barriers. So this is the message I'm driving again. Re-engagement is a process. It is not just the patient is coming, he is becoming. It is a process to engage him efficiently, effectively, so that the patient is not becoming an LFU or having a treatment interruptions in the subsequent visits. Yeah, so these are different ways that you can do. This is just an illustration of how to do it. Okay, and yeah, so this is in more about re-engagement into care, but I think you will have again subsequent sessions on how do you manage a patient who is presenting with a viral load greater than 1,000. So you do an EAC there, and once the EAC is done, you identify the barriers, try to ensure that the gaps of the barriers are filled in. So this is in brief, but a very impactful outcome that we need to understand after this session is that we need to follow the patient-centric packages of care, which is going to seamlessly reduce the or understand the work flow within your centers. Prioritize the patient who should be getting the maximum care. Prioritize the patients who should be getting a differentiated package of care within those who are stable, and definitely follow have a hawk eye on patients who are re-engaging into care and provide them a welcoming ecosystem within your own ART centers. Thank you.
Thank you so much, sir, for the wonderful session. Any questions from the participants, or if anybody would like to share their experiences around re-engaging LFU or preventing LFU, please feel free to unmute your mic.
Thank you.
Any questions?
Hello,
Yes, sir.
I'm Dr. Shivkumar from JSS Medical College. How
Yes, sir.
far that the CARG is successful? Yeah, we have the refill groups because we have not tried. How far it is successful? I want to know.
Yes, sir. From JSS, sir.
Yes.
Okay, I'm an alumni of JSS, sir. Okay, thank you. So, see, these cargs were tried in states. Number one, we have done 3 different types of cargs. As I told you, I'll just show you this slide so that you understand what are the different models and how much is it successful. For example, if you take these group models, in the group models, what we have done is you just have to identify the group of patients. For example, if they are coming from one TA NGO, what we have done and seen is the patients are able to come either every month, or there is an outreach worker from here going and offering the drugs, because within the TA NGO there is a facility that you need to contact the community maybe every month or every 15 days. So at that point of time there is an opportunity to actually offer drugs and provide that counseling. So good results among TI. And in northeastern states, the states have taken up, like, the epidemic there is more of pivots, that is injecting drug use. So there, a patient, when they are coming for their pickup of OST, so at the same site we were also putting up antiretroviral therapy. So this is like a co-located OST and ART. So at the same point you get both the things, and there is a monitoring of your drug. So this is another model, again under the key populations. And children groups we have seen. And but I mean, we, actively we did not look like, I mean, at least I have not seen like having a community that is, for example, there are 6 members from one locality and one of them is coming on behalf of them and picking drugs and going. So that sort of thing I have not seen. And other example from Nagaland which I can share is there are very good church communities. So some of the pastors actually come on behalf of the patients, collect them, and during their community gatherings, they actually dispense drugs. So there are different ways. And what we have seen is there is no reduction in the retention. So that is our outcome that we are seeing. So the outcome that we are assessing is whether the patient is is taking drugs regularly, number one. Second is what are the viral suppression rates among these groups. So these are the 2 things that we closely monitor.
Thank you, sir. Thank you.
Yeah.
Any more questions? So I don't think there are any questions. Thank you so much for facilitating this session.
Sir, good afternoon,
Yeah.
sir. Ramesh, sir.
Yeah,
Sir,
please tell me.
I am Anil, sir, Rajahmundry ART counselor, sir.
JSS alumni.
Okay. Anil, tell me.
Sir, మనకు patient transfer in ಮೇಲೆ ART patient.
ಅವ್ರೊಬ್ರು ಮ್ಯಾಟರ್ ಮಾತಾಡ್ತಾರೆ.
Also, can you please unmute again?
Hello, sir.
Yes, sir. So we can
Hello.
hear you.
Anil.
Sir,
Tell Anil.
patient transfer in మీద వచ్చారనుకో.
Okay. Okay, ma. So a patient is getting transferred in, right? So you want to know where you want to categorize that patient. The guideline is the same. If they are on ART for more than 6 months and have a viral load, okay, if it is unsuppressed, he goes into C. If it is suppressed, they go into B. If he is less than 6 months and you're getting in as a transfer in, then you put them under A or A plus, depending on the CD4 count. Okay, Anil?
We'll wait for another 2 minutes for taking up
Yeah.
questions. Any more questions? Dr. Preeti, ma'am?
Yeah. Yeah. Good afternoon, everybody. I'm Dr.
Ma'am, you'll have to speak a bit louder.
Hello, I'm audible now, ma'am?
Yeah, a bit louder, ma'am,
Yeah,
please.
yeah, yeah. Good afternoon, everyone. I'm Dr. Preeti from Sathi. Ma'am, I just a question to Sir, ma'am, both of you. Like, this is out of my experience because there was one unwilling patient. I mean, they were not ready to accept that they are positive. And even after counseling, I mean, it was like not only the situation for the couples, I mean, they had two kids. And we were like doing follow up for the 6 months EID testing. And there I got to know that this even the parents are not on ART. So ultimately, the patient were unwilling after I myself went away for counseling in all the different ways which I could technically, then in the social aspect point of view, in all these aspects. But ultimately, they didn't, replied back to me. But yeah, to the system that no more follow-ups, or else they put up a case and all that things.
I know.
So
Yeah.
yeah, in such situations, also can we, I mean, shouldn't there be an integration with the other healthcare models like the NHM? Example, with children going for vaccination. So there should be some kind of a marking system that this is marking or some kind of an identification wherein, at least that follow-up testings like the 6 months EID testing or, to link for ARTs, there should be some linkages from that end so that at least for these cases, whenever they receive care, any healthcare system, any care from a healthcare system are tracked thereby. Yeah, obviously, when it comes to the ART, that is their obviously the ARC centers are for these patients. But what if they are not willing? So I really thought if the other NHM could be pipeline to taken into consideration for additional putting additional some efforts to help us link these patients because ultimately for one issue is the contact numbers. They give us the wrong contact numbers. The other thing is they will block. Even after home visits, we have some limitations. We won't be able to just push him through them. Even after, although after that also we try to do. If not the same
Yeah.
male, then the female we try to pursue because she is a mother. But sometimes, yeah, the issues are also like she won't be the decision making partner. So she has to depend on her husband or a partner for the further
Correct.
testings and all. So this was one of the issue which I felt, and I really felt at that time that like vaccination, child vaccination was one of the opportunities which I felt was,
Yes.
there somebody,
For
if they
testing.
take a responsibility of counseling and integrating. I don't know how I just thought about discussing so
Yeah,
that
good
we can.
point, Dr. Preeti. So, the current EVTHS guidelines, I think they are almost in the pipeline. So, I think the first two chapters are exactly what you have spoken on: how to do that NHM, how better to have that synergy between NHM, ART centers, not just ART centers. It is between the ICTC here. So, I think that sort of NHM convergence and what you spelled out in terms of the vaccination day, the VHN day, all these are now part of it. I think it only now needs more focus on how better to implement them. And one thing is, I really congratulate you because you have done so much. That's how you're coming up with that case. There are, I mean, even if I ask a story from each of you who is attending today this call, you will tell me about such patients and your efforts. So it is only try, and whatever we could do the best possible is what we are doing. Yes, we will definitely have some cases, but you have given your best. That's what I can say.
Yeah, thank you so, but yeah, I just really felt that this there should be some direct, so at least for this specifically, like this we have one opportunity for vaccination, at least for the children, wherein we can take, where we have some for the parents, we really
Correct.
can't
We can't do
pressurize them.
anything.
Yeah, but at least for the children, if there is one more chance, opportunity we have, wherein we can try
Hmm,
to
hmm, hmm.
counsel them. That's what I
Correct.
wanted to say. Yeah.
Sure.
So,
Thank you very
thanks.
much. Yeah. Yeah.
Thank you, Preeti ma'am. Any more questions?
Hello.
Yes, sir.
This is Lappa from ARD Plus Center District Hospital, Duinsang.
Yes, sir.
Hello.
Please go ahead.
Hey, yeah, tell me.
Sir and ma'am, I have one question. Like say for atoll, for eligible client, like for atoll, we are giving MMT. But like we can't give MMT or like 2 months dispensing to the pediatric children. The problem is like both father and mother is eligible for MMD, while for the children we are giving only for 1 month. And usually what happen is like parents, they are supposed to collect after 3 months, but for their kid they have to come every month. Because of that, what happened is like uh, uh, sometimes the children, they miss the medicine because the parents could not be able to come in time to collect the medicine, those staying in the far-flung areas.
Yeah, so I'll just respond to that quickly, ma. So if you read this one slide in our own guidelines, so why this stable concept for children had come up is if a child, you see the third point under children greater than 2 years, if a child is there on the same regimen with no dose or formulation change for at least 3 months, okay. So
Yes, sir.
now with DTG 10 mg coming in, and you have not many changes based on the weight, so yes, in these situations with the availability of drug at your center, and I know Tuyansang, I physically came there twice or thrice, so yes, you could offer that. That is the reason why the guidelines have brought in the definition of stable for children, and the same case that you repeated was discussed, and that's how this is given. So if a child is there stable, and if the and there is no I mean, if it doesn't warrant for you to change the dose of the drug, okay, frequently, then the child can be offered, and the child can come along with the parents every 3 months or 2 months, whatever is the pattern there. And this is all again availability of the drug.
Okay, sir. Thank you so much.
Yeah.
Would anybody like to ask any more questions? Please feel free to put your questions in the chat box. So just 2 more minutes. We'll just wait.
Hello.
Yes, ma'am.
Anji, when is the MFT is going to start?
Ma'am, we are unable to hear you. Audio is not clear.
MMD हम कब से शुरू कर रहे हैं, क्योंकि अभी 1 month की डिस्पेंशन चल रही है ना, तो हाई लोड सेंटर्स में बहुत रश पड़ रहा है.
Yes, madam. NACO will address that.
हाँ जी, तो मैं अकेली हूँ अपने सेंटर में, रोज का 400 पेशेंट का ओपीडी है, तो बहुत मुश्किल होता है.
Say, madam. Yeah, that I think we are able to understand. Just, I mean, I think it'll come up soon. It'll come up soon.
वजह से पेशेंट ना मिस कर रहे हैं मेडिसिन, वो आते हैं, वेटिंग पीरियड इतना ज्यादा हो जाता है, वो वापस चले जाते हैं, तो इसलिए भी मिस एलएफयू बहुत बढ़ रहे हैं हमारे सेंटर में, क्योंकि दे डोंट गेट अ लीव फ्रॉम द वर्क प्लेस एवरी मंथ.
जी, noted, ma'am. Noted, ma'am. Any more questions?
Nothing.
Thank you so much, sir, for facilitating this session.
Madam, good evening.
Yes. Good evening,
Good afternoon. How about giving proxy, madam? If husband and wife both are reactive and coming for
Yeah, so
better.
that's not actually proxy, So this is one important message again. Husband and wife or children, they are not proxy. They are caretakers or care providers, right? So
No,
when
no,
I
no,
know,
madam. No, sir.
hmm, hmm,
I'm not telling about children. If both
wife
husband
and
and
husband,
wife are reactive, can
uh,
husband come and collect the pills for the wife, and next month wife coming and collecting for the husband? Can we do that?
yeah, yeah. If both are stable, you can do that. I mean, that is what is the family-centric package of care we are talking about.
Yes, yes. Well,
Yeah.
this also is considered as a proxy only, no, sir?
This for you it is a proxy, but if you do that family-centric package, this is this is where we miss
Uh-huh.
sometimes what we think is their proxy actually is like nowhere related, okay, and somebody else is coming. But if it is a
Okay.
own family member, you treat it as a caregiver, okay, more than or a
Okay.
treatment buddy sort of thing. But when you're
So
writing
in
in your register, you usually write it
uh,
as proxy.
in search also there's an option called proxy. We need to select. For husband and wife, should
Yes,
we select it as proxy or what should we do?
it will be proxy only, no, whatever you're
Uh,
practicing, but you should be knowing if
uh,
they are family, if you should
uh,
first know that they are family members. That's what I'm saying.
yes, yes.
If you know
Yes, sir.
family, that's okay. Yeah.
Recently, in a virtual review meeting, we were told like proxy should not be given. Make sure that the patients only come to collect their own tablets.
That's what I'm
We were
saying. If
told.
you're practicing this package of care and if they are in B
Yes.
category and if they are stable,
Yes.
and if their financial status is not supporting them for two people, then
Mm.
definitely this is the person-centered care that we have to look
Mm.
into.
On alternate months, at least we can give them.
Yeah. Yeah. Yeah.
Yes. Thank you, sir. Thank you, sir.
Pratik sir, would you like to come in?
मैं ये कहना चाहता था कि जो पेशेंट पैरालाइज है तो उसको हम कब तक मेडिसिन प्रोवाइड करेंगे, उसको प्रॉक्सी के जरिए या हमारी आउटरीच फैसिलिटी विहान के जरिए?
Yeah, I
पेशेंट
think these are critical cases like in state of paralysis, bedridden. We will have to look into the same mechanism, either if there is an outreach staff from CSC who can visit, or on behalf of the patient, somebody is coming to be. We need to continue. I mean, it's a genuine reason. But only thing is, we need to also understand the reason if it is paralysis due to some stroke, something and unable to come. But whoever is going to give the drug from the center side or from the community side, they need to understand the physical status, looking at whether the patient is deteriorating, what is happening, and at least tell the medical officer so that possibly we could at least ask them to go for a higher referral for other ailments, not just for HIV. Okay, so that is one thing, and there is no right or wrong answer in terms of how many days you will give, how long you will give, because these are critical patients who will require for a longer period.
डायक्लो दे दाखव बस विटामिन डी डायक्लो एक 2-3 देऊन टाक ते औषधावी चालली असते विटामिन डी डायक्लो
Kiran, can you please unmute
कॅल्शियम
Dr. Ma'am? Yeah, so we have one more question in the chat box. Can community CARG be considered as proxy? Any CARG model?
No, those are not actually proxy, because the patient is getting the drug. The patient is getting the drug and there is a dispensation happening. That means SOCH will be open. For example, if there is a TI or a co-located OST prescribing the drugs in a community, they will fill in the SOCH. They get a SOCH ID from SAGS and they will be filling in the drug for that patient, right? It's like a link ART. In link ART, though the patient is not coming to the nodal ART, there's a link ART where the dispensation is happening and patient is coming for a pickup there. You use SOCH at the LAC level so that the drug monitoring within SOCH happens. The same thing, you have to consider this as a link ART center where you're giving for a group of patients coming from the same community or occupation, or we can discuss who what, but they will definitely not just be looked at as a proxy, because there is somebody actually reviewing the patient status during the visit when the patient is coming.
Thank you, sir. Next question. What could be the starting point for categorizing and labeling patients at the ART centers?
What could be the starting point? I mean, do it from today. Yeah? There's nothing. There's no muhurta for this. Already guidelines are 2 to 3 years old. So by now we should have done. So you can just start from tomorrow. Every patient who is coming can start doing that.
Yeah. For how many times can we give proxy in family-centric care?
Okay, so in family-centric care, that's what I'm saying. If somebody is a stable patient within in a family-centric care, okay, so it is better, number one, to understand that everybody has their viral load. Until they do not have their viral load with you, they need to come. Once they get their viral load and somebody is suppressed, let that patient not come, and the other patient who is not suppressed will be coming to the center, because you need to take care of him. And then initially when you start this patient-centric package of care, you actually give that same message to everybody, like how they should be taking care of each other. Okay, and definitely they should be coming to your center at least 3 months once, so maybe every alternate day, so you are seeing them at least every alternate month, so one can alternate for each other. Okay, so it will be like, and in the next 1 year, if you see before their next viral load, you'll at least see them 6 times.
ARTC Guntur, would you like to come in?
And good afternoon, madam. One more clarification I want.
Yes, ma'am.
For children, school-going children, they would not like to miss their school attendance every month. In such case, can we give the tablets to their parents for 2?
Yeah, so for children, this is one critical group, ma. That's what I was saying. If you think that the weight change or the dose is dependent on the weight change, then we need to be very careful. Number one. Number two is, you should definitely first know that the child is doing well. You need to have that weight monitored, at least the weight monitored with you. And yes, you can give this because the child is not coming to you, and ask some very specific questions, whether the child is having a good growth, or is he having some intermittent illness. You need to actively ask for this, though you can give them the drugs, but you need to see the child at least every 2 months. Possibly for them, you need to give on a Saturday afternoon. Okay, maybe they have a second Saturday. So these patients, you need to ensure you give them the dates during their holiday. Every second Saturday afternoon in some states is a holiday. So on that day, possibly if you give a date, then the child and the family can come together. So ఇలాంటివి కొన్ని try చేస్తూ ఉండాలి.
Yes, sir. We even tell them to come on general holidays because the schools are, they don't have to go to the schools on general holidays. We tell them to come on general holiday also, sir.
Good. Yeah.
Yes, sir. Thank you, sir.
Thank you, ma'am. Dr. Usha, ma'am, do you have a question? So we'll take a question from the chat box. If there's a PLHIV who's on ART for the last 3 years, however, his viral load has never been done, which category he should be put into?
Okay. So just identify the reasons why the patient had not got the viral load. So one thing, if I ask you all, I think 50% of you now will answer me that possibly their adherence is not good. That's why I did not refer them. But the guidelines clearly says, refer the patient for their routine viral load testing process at 6 months, 12 months, and annually as per these timelines. So first thing is, identify why the patient is not referred. If you think that there is an intermittent coming and going, put him still on category A. Okay, because you're still monitoring that patient based on the CD4 itself, not on viral load. So this is an urgency for you, because when you look at your own center, if you have more patients in A, that means you have more work. So that will enable you to at least understand why that patient is not getting their viral load and start referring them faster. So the short answer is, put them in category A, get the viral load ASAP.
Thank you. There's one more question. As per the NACO guidelines, we can link out a patient from parent ART center only after providing 3 months drugs plus 1 month buffer. Can we link out with 1 month drug to the link ART center in view of drug shortage?
No. I mean, the guidance remains the same. There is no change in guidance. So only when you have sufficient stocks, please do that. Otherwise, we do not currently have that robust mechanism of drug delivery to some peripheral sites. I'm not saying everywhere, to some peripheral sites. So patients should not be stuck up between this. So please ensure the guidance, whatever is there of 3 months plus a buffer. If it is available, then you start referring.
Any more questions?
Good afternoon, sir. I'm from Goa sites. There are some patients of ours, like working patients, but who are not on TLD regimen. They ask for 3 months medicines. They are stable patients, but on regimen other than TLD. Can they be given 3 months medicine?
So that's what, if you see that stable definition, no, that's what it says. I mean, irrespective of the regimen, if you are there, but if it is a second line, to ensure that viral load testing be done at 6 months, possibly at that you need to weigh in. So for a stable definition, you just need to understand whether the patient is stable. But why are we giving the 3 months for these patients? Number one, what you need to understand is, even though there are critical stocks, if you start giving, when do you give at all during times of critical stock is because you're not able to give him that 3 month stock, he cannot come from his residence to collect the drug. So if there is that critical challenge that the patient is facing, only then consider. Okay, if he is stable on second line and is there, because we did not do this categorization based on any regimen. We did not do this ABC classification based on which class of therapy the patient is on. We have just done it based on viral load for B and C. For A, we have done primarily on CD4 into A and A plus. So the answer is, if that additional 1 month or 2 months of drug is going to help the patient to improve his adherence, improve his prevent treatment interruption, please go ahead.
Thank you, sir.
And all this is, again, please look at the stocks. If you just start doing things, no, only when, and you have to get your SACs on board before you do these things. The SAC should be really, because they monitor critically the state level stocks. Your center may be having, but the side center may not have. So these all, again, you need to please contact the SACs when there are critically, if you are having more patients are opting for it. So that, again, please consider when you're doing an MMD in the absence of drug stocks.
Yes, sir.
So there's one question in the chat box. KP population presence viral load कितने months बाद करना है?
You do annually, no? Same, 6 months, then annually. Every 12 months once. Initially, after initiation, 6 months. After that, at first year, then you do it every year, annually once.
Right.
There's no discrimination whether you are a key population, not a key population.
Is it a mandate to have adherence of more than 95% for 3 consecutive months for PLHIV who were never tested for viral load?
Yeah, so no need there, because that's what the guideline, in the guideline, we never told that for your first viral load or your routine viral load at 6, 12 months of testing, you need that. You can refer your own guidelines. So they never tell that. Answer is, at a scheduled viral load, we need to refer them, regardless of adherence.
Any more questions?
Yeah, hello, sir. This second time I'm asking one question, sir.
Please go ahead.
Hello.
Yes, sir.
Yeah, go ahead.
is there like any provision to train the ICTC lab technician for collecting this viral load sample? Because those people staying in a far-flung area, they are unable to reach the ARD center at a specific time. Because of that, we have a lot of wireless duties is there. So if ICGC network is being like trained on collecting this viral load sample and separating the serum and sending to ARD center, I think it will be much helpful for
Yeah,
us.
I think we have also done that, right? We did some camps in those ICTCs, LACs long back. That can be done if SACS is on board. They can train and do it. It's actually happening in Manipur, Mizoram, Nagaland. It's actually happening. Like for example, earlier you were from Tuensang. So patients, when they are not able to
Yes,
come
sir.
to Tuensang, we were collecting in Noklak when it was not an ART center, and the samples were coming here. So yes, this is an opportunity, and SACS is willing. They can train their staff. And also think of even dispensation at that link ART level or ICTC level, because you are saying the patient can't come. So if they are coming for viral load, then it's an opportunity to ensure the decentralized dispensation at that site.
Yeah, since we have got CARC also in some of the places.
Yes, yes.
Okay, sir. Thank you, sir.
हाँ सर, ART जमशेदपुर सर पूछ रहे थे कि जैसा आप बताया कि वायरल लोड 6 मंथ पे करना है जो फर्स्ट रजिस्टर पेशेंट है, और लेकिन CD4 सर कितने कितने दिनों पे करना है फिर?
ठीक है, वो फर्स्ट बेसलाइन करना है. Okay, then you also do it next 6 months. Once the viral load is suppressed, okay, so if the viral load is less than 1000 and the CD4 count is greater than 350, ठीक है, CD4 count is greater than 350 and your viral load is suppressed, then you will keep doing your viral load annually, okay, until the viral load becomes unsuppressed. You again will not do a CD4 count.
अब बीच में तो उसको नहीं, जैसा मान लीजिए 2015 में हुआ है उसका CD4 और उस समय
Okay.
था उसका मान लीजिए 600 या 700 कुछ भी समथिंग था, वायरल लोड सप्रेस्ड था, तो उसको फिर रिपीट नहीं ना करना है.
CD4 उसी टाइम में concomitantly we have to take the specimen. For example, if you have done a CD4 count on March 1st, you have done a viral load on March 1st, okay? Suppose on the same day you have done. Then if you are getting a viral load less than 1000 and that CD4 result is greater than 350, then you don't need to repeat, okay?
Okay, thank you.
Only when your annual viral load, when it is greater than 1000 next, at that point of time, you want to monitor the CD4. You want to ensure that you want to put this patient back on OI prophylaxis if required, okay?
वायरल लोड तो जब रजिस्टर्ड हुआ उसके 6 मंथ के बाद एक बार करना है, फिर 12 मंथ्स पे चले जाओ.
6 months, then next 6 months or 12th month, and then annually. 6 annually.
Sir, this concomitantly when we do viral load and CD4, viral load is suppressed and the CD4 is less than 350. For them, we are repeating CD4 every 6 months. Huh?
Yes. For them, you have to repeat because you have to take a decision on the cotrimoxazole prophylaxis.
Yes, sir. And this holds good only for first line of ART, and for second and third line, we need to do both CD4 and viral load every 6 months, right, sir? Even if they are suppressed?
Good question. Let me just check. Possibly, you will, because you are anyhow doing a viral load every 6 months, then why do you want CD4?
Because there is a footnote there. It is only for...
On second line?
After switch, yes, sir.
Okay, fine.
So in continuation to the previous question on the starting point for categorizing and labeling patients, what could be the roles and responsibilities of the ART staff?
Very good question. So I think the places where they have done this sort of categorization is the counselor actually looks into the what is the duration the patient is on, and if they are eligible for their viral load, and if there was a recent viral load that is done in 2 or 3 months period, and if it is suppressed and the patient is not having any other treatment interruptions, so there they could do that assessment, and the final decision could be taken by the medical officer, and they could write there with a pencil or something on top of the card A plus. And when you're putting the cards back into the racks, then you could do that color there. So it's like the counselor or the staff nurse assesses the duration the patient is on, then whether there are intermittent OIs or something, whether the patient is on specialized care. So the stable definition or unstable, and then the viral load, and if they are treatment interrupters based on that, and you just write on the white card. I mean, in the what I was telling during, or what most of the facilitators during the capsular training were telling you, is that you need to have a meeting every day afternoon. Similarly, have a meeting in the afternoon in the coming days, sit down and say where the counselors will write with a pencil, and medical officer, when he sees that, can take a decision. And if he checks it off or says it's okay, then somebody who is putting the card back into the rack, or the medical officer itself, if he has a pen there, they can just put a mark there. That's how the color codes are given. But don't do it without the physical presence of a patient. What happens is, some of them enthusiastically, what they have done is, they have just taken a list of viral load whoever are suppressed, they pulled those cards and they started to circle them up. But those viral loads were almost 2 years back, 3 years back and all, and the patient actually is not coming. So that is a risk you run into if you do not do this categorization while the patient is coming for a pickup.
Any more questions?
Yes, madam. Yes, madam. And just now I asked, sir said he would get back for that question. Concomitantly viral load and CD4 is done for second line and third line. Even if viral load is suppressed and CD4 is more than 350, we have been repeating every 6 months, both CD4 and viral load. Are we right is one question. And we have many second line as well as first line patients on dolutegravir regimen. Viral load is unsuppressed. We give them step-up adherence counseling and repeat the viral load after 3 months, making sure that their adherence is more than 95% in the previous 3 months. But the viral load comes down probably by 50% or so, but it is not suppressed. Initially, it was some 20,000,
maybe 1 lakh,
25,000.
it comes
come down
to 50,000. Yeah.
Yes, sir. Yes, sir.
So,
and it shows a downward trend.
Correct. So
what should we do, sir?
Yeah. See, now NACO is anyhow coming up. In the past ERG, there were discussions on this. So you can prolong the EAC if the patient is not so if the patient is not so sick, and you could take a chance, please take a chance, because what we have seen again in the same AP data is, if you are doing that patient after 3 months, okay, and you do a viral load of those, if you have 100 patients who were unsuppressed, if you do a good EAC and repeat the test after 3 months, almost 70% of your patients are getting a resuppression. Okay.
Yes, sir. We have observed. We are observing the same.
Correct. Exactly. Now, the second half of the story is, these 30%, if you prolong them again for 3 months, and if they are not so critically ill, what the observation is that, again, 60% to 70% of them were again resuppressed. So don't take a very hurry decision on patients who are on DTG, because you don't have any other effective drug for them. Please see that the regimen is really sequenced properly, not just using it left and right. Okay.
We did this previous 9 months, sir, almost. So we have not initiated on second line ART at all for in our center, ART plus center. So will we be questioned? You are not doing any work at all. That is another doubt, sir.
See, you are only not switching, but you are doing the work. You are conducting SASEP. No? What you are doing is, you are not switching erratically. You are trying to gauge what is the benefit. for the patient.
This
Yeah.
also, so this decision also has to be done in SASEP meeting only, right, sir?
Exactly.
Yes, sir. Thank you, sir. Thank you so much.
Thanks. Thanks. Yeah.
Thank you so much, everyone, for the active participation. If there are any more questions, please write back to us and we'll forward the questions to sir, and then we'll send them the answers to you. Thank you so much, sir, for the extended period of time.
No problem. Yeah. Thank you. Thank you all.
Thank you, sir.
It was really active participation. Yeah.
Yeah. Thank you, everyone. We'll conclude the session now.